guys, what is going on? If you haven't met me, my name is Michelle and I'm one of the admins here in Outpatient OT. I work in Outpatient and I pop in from time to time to just kind of share maybe what has happened today or some thoughts about the occupational therapy profession, just to kind of get you thinking a little maybe outside the box, if you will. But today I wanted to jump on, I'm about to leave for the evening, and I wanted to touch on something that happened this evening in my evaluation. So being an outpatient therapy business owner in the adult population, it's very common that I'm explaining how occupational therapy can help my clients. Why would they come to an occupational therapy practitioner for movement-related diagnoses or to have remediation after an orthopedic procedure? Why come to an outpatient OT versus a PT or along with a PT? And so individuals who find me who are referred to me, they are still on the fence about what I am bringing to them or what our clinic is bringing to them because they have one idea of what occupational therapy is. They have that stigma. They have that stigma that's attached to an occupational therapy practitioner, where OT equals ADL. But we know that OT does not equal ADL, and we have to be able to explain that in a competent manner, where we're leading with our intellect. We're leading with all of the ways that we can truly help somebody. Now, with that, one of the individual I was evaluating, he had said at the end of every treatment or at the end of every evaluation, I will ask, okay, so based on everything that we went over today, based on what you feel about where our plan of care is going, because we'll have that conversation, I'll ask, what do you think? Do you feel like this is going to be a good fit, and what are your thoughts? And so this individual had said, well, I know that my daughter was in occupational therapy, so coming here, I had an idea of what to expect, and you, at the start of your evaluation, you basically confirmed what I had thought. Regarding, like, OT asks about dressing and self-care and, things that I do. And so you basically confirmed that, and I don't see, why I need to be with you, because I need to get up and moving. I need to have be able to get back to doing, walking around safely and my posture and things like that. And he started listing all of these things. So let me explain my evaluation process. I start with Lott and Brody, CATS ADL, ABC balance, and slums, just to kind of get an idea of where we're at in our headspace and in our functional performance profile. That's where I start. And then I will head into the physical performance skills immediately following that. So right after that, I do my active range of motion screen. I will do manual muscle testing, tug, 5 times sit to stand, tandem walking, and whatever it is that's pertinent to that diagnosis. This particular individual has a diagnosis of Parkinson's with an exacerbation of symptoms secondary to COVID, being isolated. And so he's having this kind of acute decline. And so it's important to partner that. Regardless, you're always starting with occupation, right? Because you want to get an idea of what activities are being impacted. This particular individual enjoyed hiking, loves being outdoors, and his wife and him want to be able to travel in the coming months, this summer. Now, I explained to him why we were doing what we were doing. I said, yes, we absolutely start as an occupational therapist. I need to know what's being affected. So I heard from you that you enjoy hiking. And so I know that as I help you remediate your posture, and as I help you get better with your walking and being able to go over hurdles and obstacles and going up and down stairs, as I help you do all of these things, I'm working towards your ability to go out and hike in the woods safely and productively without the need of a walker. And so I was able to bridge that together. Okay, so that's the context of this whole chat, is that there was a lot of distrust and a lack of buy-in with this individual because OT in his mind was just about ADLs, and he couldn't come out of that. He couldn't come out of that. All you do is care about my activities, but you don't actually know how to help me get there. That's physical therapy. And so that leads me back to education. When we are in academia, we are taught, have your OT elevator pitch ready. In fact, classes upon classes ask you, well, how would you explain OT if someone asked you? And what do they immediately say? They say, don't lead with we're like physical therapy, but. So automatically, we're kind of put into this position where we shouldn't be calling ourselves or referring to ourselves as similar to a physical therapist when we're in all of the same classes. So that's very confusing, right? So then if we can't say we're similar to physical therapy, well, then how do we explain our profession? And then this is what comes out. We put the fun in functional. OT, nobody knows what we do. What are some more? Like I said in the comments, PT helps you walk, but OT makes sure you're not naked when you walk. Oh my gosh, I hear all of these things, and it's frustrating because how is this and this something that, like, what I went to school for how long, and I have this many certifications and this many credentials next to my name, and then I'm reduced to put the fun in functional and OT, nobody knows what I do. If these are the kind of ways we're explaining our profession, that might be a barrier to the success of that might be why we're facing like an existential crisis. And that's what I heard over and over again at these conferences that I've been at, these people who are explaining why OT is having such a difficult time. People are having a hard time finding jobs. We're getting paid less and less money. We're getting less and less referrals in every level of care because doctors don't even know what we do. They all equate us with ADLs. So when it comes down to have your elevator pitch ready, we need to understand what we're up against in the community. So were you prepared for the level of resistance you would face? How could this have changed? So think about your program. Think about the program you're in right now. Is your program preparing you to sufficiently and competently advocate for the OT profession? Is your program doing more than just saying have an OT elevator pitch ready and guiding you into, okay, what kind of questions are you going to ask? So when you walk into someone's room in a hospital, they're going to say, well, what do? You say, hello, I'm your occupational therapy practitioner. And then the person goes, oh, what do you do? If you lead with, oh, I'm going to help you get dressed, that's not what you're there for. You are not there to help that person get dressed. You are there to ensure that an individual can perform all of the motions and skills required to maintain independence. If you say, I'm here to help you get dressed, they're going to equate you with a certified nursing assistant, which I love my CNA friends. I respect what they do. I respect everybody in the medical field, but I am not a CNA. I am an occupational therapy practitioner. You have to ensure that you use the verbiage that is going to effectively portray your competence. If they hear that, they immediately think that you're not there to help them move. And that's ultimately what they want. So your OT elevator pitch or speech or education needs to ensure that your client truly understands who you are, that you are educated, that you do remediate the body to ensure maximum independence. So Mr. Smith that you're going in to help dress, well, he can't bend more than 30 degrees without feeling dizzy. And so how is he going to be able to move? Because really that's what he wants. He wants to be able to perform bed mobility and dress himself and get up and down and go stand by the sink and have the dignity of getting up and going to the toilet, back to the bed. He wants dignity. So how can OT leverage their skills to help get him there? It's more than just, I'm here to help you get dressed. So how do you explain OT? Would you trust an OT to help you move and function if you heard your explanation? If you suffered a CVA and no longer had use of the left side of your body, and somebody walked into your room and you're sitting there and you have a hard time communicating, maybe you're you can't get the words out of your mouth, and someone walked in and said, hi, I'm here from therapy and I am going to help you make sure that you can do everything for yourself. I don't know what that means. I don't know what that means. And I just want to go to physical therapy because I don't need to do things by myself. I need to make sure that I can move my hand and I can move my body. I don't care that you're functional. I don't care about that. I don't even know what that word means. I'm helping you do everything, functional, all of your functional, meaningful activities. I don't care about functional activities. I care about movement. I care about bending. I care about using my hand. So we have to make sure that we're using words that your clients can understand and appreciate based on the context. It's not just one OT cookie cutter elevator pitch that you can say in under 30 seconds because the OT profession is so mammoth. We study so much. We look at the whole person, right? So we are going to address somebody's mental health. We're going to address someone's psychosocial skills. We're going to address the physical remediation, the physical remediation of their body. We're going to address neuromuscular communication and control and modulation of movement. We're going to address so many of these things all in one profession. It's going to look differently for each person. So think about when you're thinking about how to explain the OT profession, make sure it's relevant to the person, because Mrs. Smith who has let's say Mrs. Smith has Guillain-Barré. She is going to need a different explanation of how occupational therapy is going to help her than Mr. Smith down the hall, who just had a bilateral above knee amputation and now needs to go home, where he has a dog sitting at home. He lives by himself and he's been going through this decline secondary to diabetes, and now, oh my gosh, how am I going to be able to do these things? Well, I'm hooked up to 2 wound vacs, right? So what is that OT going to look? How is that going to look different than Guillain-Barré OT? We have to make sure that we are aligning to the client, not to how we feel OT should be explained. So you must know without any doubt who you are and everything you offer. As an occupational therapy practitioner, you are amazing. You are amazing. If you're a student, a new practitioner, practitioner, OT is phenomenal, and we have so much to offer in every single field, in every part of the remediation process, so much more than ADLs and IADLs, and you have to be confident in that. You have to be confident in billing through the biomechanical model. You have to be confident that even though your activity includes ankle weights and bicep curls or lunges or whatever, you need to make sure that you are confident in doing that you can do it. And if you're not confident, talk to me, because I'll just go ahead and pump you full of the confidence you need to bill for your service, because I've been doing it for a long time. You must know and be confident in who you are and what you have to offer. When you're talking to another medical profession, when you're talking to a doctor, believe me, I've had a lot of conversations with doctors. In fact, I remember a couple years ago, I walked in and I was going to speak with an ortho MD, and I was talking to him about future referrals, and he said, well, I would never refer to an OT because you guys don't you guys don't work with the shoulders after a surgery. Most of my clients can get dressed. And so when I heard that, it's like, wow, you don't know what we do. I was a year after that, I was speaking to a neurologist, and I said, well, what do you know of OT? Why do you think you would refer to me? And he said, you guys do like the upper body, right? Like the waist up, and you help with like grooming and stuff, right? And that just kind of opens your eyes to, you have to be so confident in your own profession so that you understand how to advocate for it among the medical professionals in skilled nursing. When someone tells you, hey, you shouldn't be doing that, you should defer to physical therapy or speech therapy, you need to understand your place and why. What is your role there? What is your role in that holistic approach to therapy? And then how can you be that bridge between PT and ST? Because we overlap. I wonder if I can show you. Check this out. Okay, guys, look at this. Look at that. That middle one is occupational therapy. You see that? We overlap, and that's okay. Be proud of that. Don't be ashamed to that. You don't have to dim your light so that they can shine. Everyone can shine here in the allied healthcare field, but we need to step up and into that role, okay? Lastly, be ready to explain yourself so that your patients do not miss out on your unique ability to approach their diagnosis. Listen, if you don't advocate, if you don't tell them why they need you, if when your patient says, well, I don't want to do OT today, I just want to go to physical therapy because they're going to help me walk and that's really what I need, then you need to say, well, listen, Mrs. Jones, let's get up and get walking today. I would really love to help you get up and get walking. And you know what? Along with that, we're going to make sure that you can use your both hands while you're walking. So I'd love to address that too. So let's get up and get walking, because that's called an activity of daily living. Walking is so crucial. And I know how to get you up and walking. So let's get up and walking. And then we're also going to do some stuff with your balance. Because when you go home, you're going to need to walk your dog. When you go home, I want to make sure that not only can you walk, but you can carry your, because you love watching Jeopardy. I'm going to make sure that you can carry a plate of food from the kitchen to your couch. I'm going to make sure you can walk and carry your food safely without worrying about falling, because I don't want to see you here again. I want to make sure that you go home and you stay there, and I only see you in a social setting. So there's all different ways where you can explain yourself, explain that we are mobility superimposed on functionality. Okay, so or functionality superimposed on mobility and strength and coordination and agility. We're bridging that gap. Okay, so if you guys have any questions on that, I would love to have a conversation. Again, these are just my thoughts based on my experience here in outpatient on a daily basis of these conversations that I have, and then also my role in acute care and MRU as well as skilled nursing. I'm able to I kind of pull from all of these places, and you see this, you have the exact same conversation in every single level of care, because people need a better explanation of OT than what we're giving them. All right, guys, that's it for me. I'm out of here. I'm going home. So thank you very much for watching. If you made it to the end, congratulations. I don't know what you win, but thank you for watching, and I'll check in with you later.